Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. We've been away for a while, taking a little break. We're going to get ramped up again, bringing you the best core content. And we're going to start today with a bit of a tox trip. We have got our in-house toxicologist, Dr. Sanjay Mohan. Sanjay, great to have you back.
How's it going, man? It's been a little bit.
It has been a little too long, and that's why we're going to dive into something that is at the core of toxicology in so many different ways. It's probably one of the first things we learn about in terms of toxicology and toxicity and management, and that is acetaminophen toxicity. Honestly, though, of all of the drugs out there that can be toxic, why acetaminophen?
As with anything else in emergency medicine, it's risk-taking and pretest probability. The fact of the matter is, acetaminophen, generally sounds benign. If you're not in medicine, you know what Tylenol is in the States, but acetaminophen is in a ton of over-the-counter and prescription medications. Things like Excedrin, Fioricet, Percocet, Vicodin, Dayquil, and NyQuil all contain acetaminophen. And despite the seemingly benign nature, there's a tremendous degree of morbidity and mortality with acetaminophen toxicity.
And this mortality and morbidity is so well known and so well published upon that in other countries that are not the US, you can only buy a small amount of acetaminophen at a time. Like I was just in England and I was like, oh, I got a headache. I'm going to go buy some acetaminophen, expecting that the only option is the 1,000 pills that we get here. And they're like, no, here's like 7 tabs. I'm like, but that's going to last me like half a day. But that's
That's
normal outside of the US because they understand how bad this can be. Meanwhile, we're going to Costco buying 5,000 acetaminophen, making it very easy to get an acute overdose. So because of that, because of the access to this drug, the fact that people know it can be lethal, we're going to see these toxicities, we're going to manage these toxicities. And then, like you said, you have those patients who aren't trying to take acetaminophen as a toxic dose, but they're taking other things that also have acetaminophen in it without their knowledge, and they're just getting into these bad places. So let's kind of go to the start of all of this, which is pathophysiology. If we understand the pathophys a little bit, we can understand management as well as presentation. So give us a bit of an overview of the pathophysiology of acetaminophen toxicity.
So after ingestion of a therapeutic dose, immediate release acetaminophen is generally absorbed with a time to peak concentration anywhere between 30 to 45 minutes. In the context of extended release formulations, full absorption is typically reached by about 4 hours, and I want you to remember that 4-hour time mark. In therapeutic dosing, the vast majority of acetaminophen undergoes hepatic conjugation, which means it forms benign metabolites that ultimately get excreted in the urine. About 5% is oxidized by CYP2E1 to form something called N-acetyl-P-benzoquinonamide, or NAPQ for short. Now, NAPQ is what ultimately matters because NAPQ is hepatotoxic. In non-toxic concentrations, glutathione combines with NAPQ to generate non-toxic metabolites. So the problem really is that in overdose, in super therapeutic ingestion, the amount of NAPQ that is generated is increased as the typical metabolite pathways become saturated, and that ultimately leads to hepatocellular death, i.e. hepatotoxicity.
All right. So that's a really good overview, kind of looking at what it is that we need to know, why this becomes toxic. We do have to have a low threshold to test for this, right? We really want to capture all of the patients that could be acetaminophen toxicity. What are the presentations that should kind of be reminding us or pushing us and saying, could this be acetaminophen? Do I have to ask that question or get that test?
So first and foremost, right, I'm a toxicologist, so I think in terms of toxidromes. I look at a patient, I look at a set of vital signs and their physical exam, and I think, where is this patient going? Are they opioid toxic? Are they sympathomimetic? The problem with acetaminophen is that there's no set toxidrome. I get an asymptomatic patient who said, I took a whole bunch of whatever. I get a patient with non-specific GI symptoms, nausea, vomiting, diarrhea. So at the end of the day, at least in my eyes, there should be a low threshold to get an acetaminophen concentration in the undifferentiated altered patient, the poison patient, or even elderly patient who is coming in with non-specific GI symptoms. As with everything else in medicine, patients don't read the textbook, but classically, acetaminophen toxicity presents in 4 distinct stages. Stage 1 is generally within 24 hours. At this point, patients are either asymptomatic or have non-specific GI distress, nausea, vomiting, malaise. And at this point, hepatic function testing is generally normal. When you get to stage 2, anywhere between 2 to 3 days, the onset of hepatic injury begins, which generally means AST and ALT elevation. AST is the more sensitive marker to detect hepatic dysfunction. Stage 3 is peak hepatotoxicity. Now, this is generally between 3 to 4 days. Patients may come in with hepatic encephalopathy, coma, and AST and ALT may rise above 10,000 IUs per liter. Other lab abnormalities include your coags, glucose, lactate, pH, and creatinine. Stage 4, also known as the recovery phase, are patients who survive the immediate acute ingestion and survive to complete hepatic generation. It's important to note, if you survive the acute toxicity phase, your liver looks like every other healthy liver in the world, which is generally good.
The big things in here are that non-specific nature of the symptoms that we're going to be seeing. And I like what you kind of narrowed it down to. If you have the undifferentiated altered mental status, consider getting acetaminophen level. For everybody else, it's really about asking that question: what medications are you taking? Making sure to say, what over-the-counter medications are you taking? Sometimes patients think you just want to know about the prescription meds. What are you taking over the counter? Finding out what's in those things, and then getting some idea of the dose of what they're ingesting. And then the other side of that is any patient who comes in with suicidality, a possible suicide attempt or an ingestion, you just get an acetaminophen level regardless of what they say they took, right? We know because acetaminophen is in a lot of different things. It's over the counter. People have so much of it in the house. It happens and we often miss it. Now, the acetaminophen level itself is important to get, but what other labs are we going to get on that patient where we are suspicious for acetaminophen toxicity?
So in addition to the acetaminophen concentration, you should be getting a hepatic panel, a pH, coagulation panel, renal function, lactate, and phosphate. These labs will ultimately dictate your disposition or transfer to a hepatic liver transplant center.
A lot of our treatment is going to be based on the time of ingestion and the acetaminophen level that you get when the patient presents. But of course, there's a little bit of nuance. There is the chronic ingestion, there's the acute ingestion. Let's start with the simple one. A patient comes in after a single acetaminophen ingestion. They say they went into the medicine cabinet, they took a bunch of medications, and family or the patient or somebody else brings all of the pills. And you notice acetaminophen is one of the pill bottles that's in there. So we are suspicious for an acetaminophen ingestion. It's an acute ingestion. When should we be sending that acetaminophen level? And how do we determine if antidote is indicated?
For a single acute ingestion, I would recommend getting a 4-hour post-ingestion concentration. That way, you can plot it on something called the Rumack-Matthew nomogram, which is derived from real-life data. If that concentration is above the demarcation line, then you treat. If it's below, the evidence suggests that you don't necessarily need to treat that patient.
Here's where this becomes a little bit tricky. Sometimes the exact time of ingestion isn't known, or the patient comes in really soon after the ingestion. So they present, let's say, 2 hours after saying they took an ingestion, they regret having done it, so they present to the emergency department now, and they look fine. They have no symptoms. Are you getting a level then, and then another one 2 hours from then for the 4 hour mark? Or are you just saying, you know what, let's just wait, don't get any labs, and in 2 hours, we'll get a set of labs, including a level?
I love this question, Swami. I get this question at least once a month from my colleagues and kind of like curbside phone calls from my friends. We are stewards of evidence-based medicine. And if you believe in evidence-based medicine and believe in the Rumack-Matthew nomogram, all the errors are built into that nomogram. Patients who lied, patients who underestimated, patients who overestimated. So let's say a patient comes in 2 hours after ingestion, they look okay. You can wait, it's fine. Get me that 4-hour concentration. If a patient comes in 2 hours and you get me a level, I don't know if that concentration is going up or down. So I actually don't know how to interpret that. And as an aside, you have up until 8 hours before starting the antidote that effectively gives you 100% of protection time before starting NAC.
So we have some protection built in here, like you said, which is really important. Now, of course, all bets are off if the patient doesn't look good. If the patient comes in and they look sick, and that could be anything, that could just be mild tachycardia. That might be enough to say, I'm just going to get a level right now, even though you're like, well, I think it's only 2 hours post ingestion, but maybe it's not. Maybe it's actually longer, considering that 2 hours post ingestion, the patient should look okay. They really should look pretty well. So if the patient looks totally fine, they tell you they took it 2 hours ago, you could actually wait a little bit and then get your 4 hour level. So you actually have information that you can act on. If the patient doesn't look good, regardless of when they say they took it, just go ahead and get the level, talk to your toxicologist, and you can come up with a plan together of how you're going to manage that patient. I think everybody knows that the antidote for acetaminophen toxicity is N-acetylcysteine. That is our antidote of choice. Let's go a little bit into the dosing that we're going to use.
So here in the United States, we use the quote unquote 3-bag protocol, which is a 21-hour regimen. The first loading dose is 150 milligrams per kilogram over 1 hour. Then it transitions to a 50 milligram per kilogram over 4 hours, which is 12.5 milligrams per kilogram per hour. And for the next 16 hours, it's 100 milligrams per kilogram or 6.25 milligrams per kilogram per hour.
Let's pivot now to that subacute or chronic toxicity. It can be much harder to pick up. And even when we do pick it up, it can be much harder to treat. So, what tips do you have for recognizing this when the patients come in?
As we've kind of alluded to, that Rumack-Matthew nomogram is only for single acute ingestions. The patient that comes in with chronic toxicity that says, hey, I've been taking acetaminophen every 2 to 3 hours for the last week, you can't plot that patient. Or the patient that took two big doses several hours apart, technically you cannot plot those patients. So if a patient is giving you a concerning story, but they look otherwise well, you send off LFTs, you send off an acetaminophen concentration, and it's either elevated, sure, start N-acetylcysteine in the meantime. But remember, that nomogram is only for single acute ingestions.
So, in those cases where the patient comes in kind of with some vague symptoms, you either tease out from them that they have some chronic ingestion, or they tell you, I've been taking a gram of Tylenol every 2 hours for the last 7 days. What symptoms should they have and what lab abnormalities should we see when they're presenting? Or can everything be totally fine?
That's the thing, right? You know this, Swami, better than most. Everyone lies to us. People love lying to us. So the issue is that if you believe their story, you can get serial testing, the acetaminophen may be negative and LFTs are normal, and then you're probably okay. But depending on where they land, right, whether they come in 6 hours or 8 hours or 24 hours out, they may have lab abnormalities, increased AST, ALT, they may have an underlying lactate or hyperphosphatemia. And in those cases, if you're concerned, you should probably call your local poison control center and start N-acetylcysteine as soon as possible.
All right. So, in those chronic ingestions where the patient gives you that story of, I've been taking far too much for many, many days, you're going to have a low threshold to go ahead and start your N-acetylcysteine. You're going to get all those labs. And of course, you're going to talk to your toxicologist to help to guide management. Is there any difference in dosing of that NAC?
For the subacute or chronic toxicity, there is no difference in dosing, but one caveat I will mention. As you said to start off this podcast, at least in the United States and the Western world, unfortunately, we have tremendous access to large doses of acetaminophen. In the tox world, we've kind of labeled this as quote unquote massive acetaminophen toxicity, and there are varying definitions. If a patient comes in profoundly sick, you can alter the N-acetylcysteine dosing, but I would not do that without consulting your local toxicologist.
But it's good to know that that may be an option in a massive overdose and a good question for us to be asking. Now, speaking of those massive overdoses, one of the drugs that has been around for a long time, but not specifically in terms of treatment for acetaminophen, is fomepizole. Now, when I say fomepizole, people immediately say, oh, that's the antidote for toxic alcohols. But there does seem to be a little bit maybe for a role in acetaminophen toxicity for this drug as well.
Right. Now, I did fellowship between 2020 and 2022, and that's when this really started to kind of pick up steam. But fomepizole has recently been under scrutiny, or I should say, kind of examination for treatment in severe acetaminophen toxicity. And how does that work? It actually inhibits CYP2E1, and as a result, inhibits generation of your toxic metabolites, in addition to kind of limiting downstream subcellular effects. At this point, there are case studies, there's small retrospective chart reviews, but there are no large-scale human studies. So at this point, I would not routinely give fomepizole, but if you call your local toxicologist or your local poison control center and a patient that's profoundly sick, they may actually recommend giving it.
How do we determine if the patient has such extensive liver damage that they actually need to be considered for transplant? And for the vast, vast, vast majority of us, that means transferring them to somewhere that has a liver center.
So there's something called the King's College criteria, which is a set of lab markers that are used to determine which patient should be referred for possible liver transplant evaluation. Specifically, an arterial pH less than 7.3, an INR greater than 6.5 or a PT greater than 100 seconds, creatinine greater than 3.4, grade 3 or 4 hepatic encephalopathy, hyperlactatemia, and hyperphosphatemia. So the way I operate is if my patient meets any of these criteria, I'm probably calling my local GI team because they're well aware of this set of criteria, and then you can make next steps and decide whether this patient actually needs to be transferred or referred to a liver transplant center.
I think that a little bit of the theme we have here is having that low threshold to pull the trigger. So low threshold to consider acetaminophen as the toxic ingestion. low threshold to treat with N-acetylcysteine, understanding that it has a very low side effect profile, and a low threshold to talk to your liver team, your transplant team, your GI team about patients who look sick. It's really one of these, there's no harm in making that phone call, letting them know about the patient, and then saying, no, we don't think that person is a candidate for liver transplant. I've been surprised a number of times where I've called my receiving center and said, hey, I've got this patient. We're pretty sure this is acetaminophen overdose. Here's what the labs look like. And they're like, yep, send them to us. We'd like to take a look at them. I'm like, really? Are you sure? Because they look okay. They look pretty good. It's like, doesn't matter. With those labs, we would like to have eyes on them. We're going to keep a close watch on them in a unit so that we can see if there's any change in that. We're going to go to liver transplant. So I think it's really important to get this team involved in the care of the patient and let them determine, do you want me to send the patient to you, or do you want me to hold on to this patient and keep him in my ICU? Sanjay, before we wrap up with our take homes, is there anything else that we should know from a management perspective?
For sure. 2 points. One, patient comes in after an acute ingestion, you're concerned. They're not nauseous or vomiting, they're protecting their airway. Please give them PO charcoal. Think of it this way. If a patient is potentially above that Rumack-Matthew treatment line and you give them charcoal before 4 hours, you can drop their concentration so that you don't need to start NAC, right? If you don't need to start NAC, you don't need to commit them to admission or in 21 hours of treatment. Secondly, there's a risk of an anaphylactoid reaction or a non-immune hypersensitivity reaction. It generally happens during the loading dose, so that first hour. Reactions include urticaria, sometimes angioedema, and some respiratory symptoms. But if that's the case, diphenhydramine steroids and just start the NAC again at a lower rate.
Yeah, this antidote is so good. It's so powerful that even if the patient has an anaphylactoid reaction, we're still going to give it. We're just going to probably slow it down, treat them, and then start it again. So we just have to be really aware of this. Again, I've had this situation pop up once or twice. Talk to the toxicologist. They'll give you recommendations on how to manage that patient. In most of our hospitals, if the patient's going on a drip, they're going to the unit or step down so they can be closely watched for these types of reactions. This isn't a patient that you just want to kind of park on the floor in a corner. Not a great idea. Even if their labs look good and stuff, you usually want them to have a little bit of a higher level of care, at the very least, for that first hour of infusion of your NAC. And then once you know that they tolerate it, they're probably going to be okay. So all of this helps us in determination of where that patient needs to go. All right, Sanjay, wrap us up with some big take-home points on acetaminophen toxicity.
Acetaminophen, most commonly referred to as Tylenol in the United States, is in a variety of pharmaceuticals. Medications like Excedrin, Fioricet, Percocet, Vicodin, and Dayquil and NyQuil all contain acetaminophen. Given the lack of a toxidrome, there should be a low threshold to obtain a screening of acetaminophen concentration in the undifferentiated poisoned or altered patient. In overdose, acetaminophen leads to generation of NAPI, which is hepatotoxic. NAC, or N-acetylcysteine, is the antidote of choice and ideally should be administered within 8 hours of an acute ingestion. To determine which patient should be treated with antidotal therapy, the Rumack-Matthew nomogram should be utilized. Of note, this nomogram was validated for a single acute ingestion obtained at or greater than 4 hours. In patients with a high pretest probability of acetaminophen poisoning, the King's College criteria should be considered, which is the set of lab markers that help determine when patients should be referred to a liver transplant center. While physiologic plausibility exists for the use of fomepizole to treat severe acetaminophen toxicity, no large-scale studies exist at this time to suggest that it should be routinely given. As with all cases of poisoning, please call your local poison control center for assistance.
That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. In the meantime, don't forget to pop on over to the site, check out all the fantastic posts from our team, and until next time, stay safe.